Good morning. My name is Barbara Ward-Zimmerman, and I am here today, gratefully, representing an organization called the Child Health and Development Institute of Connecticut. And the Child Health and Development Institute of Connecticut actually does a lot of boots-on-the-ground work to do training of professional licensed behavioral health as well as pediatric providers. So I will share with you a little bit about what we are doing. I must say, though, that I want to give a shout out to Bob Franks, who is here with us. Bob worked through the Child Health and Development Institute, was a real innovator and motivator for a lot of the work that I will be talking about today. He's back there. He's now at Judge Baker, so our loss is their gain. And he really has done wonderful work, as well as Jason Lang's work that was mentioned before I will talk about also. So, the Child Health and Development Institute of Connecticut is a nonprofit subsidiary of the Children's Fund of Connecticut. And what we were asked to talk about was really kind of funding of some of the services that we have all been talking about today and yesterday. So the Children's Fund of Connecticut provides seed money to the Child Health and Development Institute of Connecticut. Does not fully fund all of the programs. I will share with you how some of these programs are funded, but at least provide some of the infrastructure for the Child Health and Development Institute to be able to function. And thinking about, certainly every state is different. Connecticut is a small state, and it's really wonderful that we have one agency like this that can really help to provide not services, but infrastructure for change across the state. Of course, other states have other constraints. The Children's Fund then serves as a financial catalyst for CHDI. And CHDI translates the fund's mission into action. So advocacy for policy reforms, conducting evaluation studies, providing training and technical assistance, and supporting demonstration projects that inform system change. Two of the programs that I would like to talk about this morning involve the training of professional practitioners. So one is called Educating Practices in the Community, acronym EPIC. This was created before lots of people got onto the EPIC system, but anyway, it's a statewide training of pediatric and family medicine practitioners. And then there's also, and this is something that Bob was very involved with, the Dissemination and Implementation Support Center, statewide training of behavioral health providers. So the training is viewed by CHDI as a catalyst for practice transformation. It is not just for education and increasing practitioners' knowledge, it's really to transform practice. And EPIC has been proven to be an effective approach to primary care practice change. So we've talked a bit today about educational programs. This is a model that's really based on the pharmaceutical company model, very well researched, called academic detailing. So what we say, we know that when folks go to a national conference or a state conference or a grand rounds, they may increase their knowledge, but it's very unlikely that they will go back to their primary care setting as an individual provider and actually transform change in their practice. So what we do, although it is labor intensive, is go into individual practices across the state of Connecticut and provide the training right there to promote change. And we really have had success in changing practice in a number of areas, including autism screening, at both behavioral health and medical, physical health care, autism screening, asthma care, pain and fear associated with immunizations. There's now 17 modules that are done. Some are behavioral health, some are physical health modules, and of course, many overlap. So the unique aspect of this is that we focus on training the entire office team. As we know, practice managers are really important folks in a practice. Nothing's going to change in that practice unless the practice manager is on board. We also need, of course, physician champions, the nurses, the medical assistants, the front desk staff, everyone. So we try to go in and provide a training for the entire staff. And one of the things that we do is, of course, we bring lunch, and this is based on that pharmaceutical. It really makes a difference. And bringing cookies. Well, our person our organizer for these, who sets up the trainings, was on a diet for a while, so she was only bringing fruit and having fruit delivered as the dessert. That was not okay. So we definitely need a nice lunch because folks are busy, and it just really provides a time. We talked about kind of nurturing our providers as well. So this is one way of giving to the providers concretely while we're also providing education. And again, the emphasis is on practice-based change. So what we're doing is identifying areas of suboptimal care, something that is not being done well statewide, bringing in information, very concrete information, and I'll give you an example in a moment, about what resources are needed, what policy change has occurred, why they need to make this change, and how they can do that. EPIC has been proven to be effective. Through 12 years of EPIC training, CHDI has helped over 80% of Connecticut's pediatric practices improve the quality of their care and expand their scope of services. We have proven to increase rates. We look at our Medicaid rates of screening for maternal depression, developmental screening, behavioral health screening. These are all topics that we go in and train on. And then the physical health services, preventative oral health care, early hearing detection. We can see how much billing is being done for those in those areas. I just want to give you an example. As a psychologist, I do several of the behavioral health trainings for EPIC. One of them is on maternal depression screening. So of course the AAP is promoting that we do maternal depression screening in pediatric primary care. We go in and make the case for why is that important, and certainly this is important for the patients that are served in primary care. We bring information, this bulletin, and now I am just stressed. So this is a Connecticut provider bulletin that we just had come out in October 2016, really supported the efforts that we had done to make sure that pediatricians could bill in pediatric primary care under the baby's Medicaid number. This was great. We have this bulletin. And then this week, I find out that the code that we are using, 99420, which is a health risk code to the baby, health risk to the baby is maternal depression is a health risk to the baby, has now been, or as of January, will be turned off nationally. So now we need to go back to the drawing board. Luckily, on my flight here on Monday evening, I was sitting behind one of our Medicaid directors. And so I asked him about this. He checked into it. He got in touch with me, and he said, we'll find another code. So there better be another code. We'll have to figure this out. But that's the detail that we bring to the practices. Really, when I think about, what expertise we as behavioral health providers practitioners have, why should pediatrics be able to do mental health services fully? You can't, and it really is a partnership. So we provide, in this case, I provide sample screening tools, guidelines for office protocols. I will sit and meet with the office manager or whoever is organizing this afterwards. We'll go back again. There's emails, there's telephone calls to make sure that this system can change. And one other really important thing that I do in the modules that I am involved in is I bring behavioral health resources to the practice. So I would never ask a practice to screen for maternal depression without knowing who are the appropriate referral resources. So I have partnered with, it used to be an Alliance for Perinatal Mental Health in Connecticut. We've just now transferred into one of the first state chapters for Postpartum Support International. We are training the workforce. I have referral resource directories. I bring not only the referral resource directories, but I bring people. So somebody from Nurturing Families, from the McV program, from Child First, which is a homegrown Connecticut program. I don't know, many other states are now developing Child First, but it's an in-home parent-child intervention program, and private practitioners who take insurance. So we do have in-home CBT. I would not bring folks who do not take insurance. So it's really all about the partnerships, right? And I was in Africa last year. I now very much understand that partnership that's there. But in terms of EPIC, there are funds that are secured through state agencies. So it's really this opportunity to work with one another, to foster each other's advance each other's agendas. So the Department of Public Health has supported our suicide prevention talk, the early hearing detection talk. The Office of Early Childhood has partnered with CHDI for the postpartum depression talk, infant mental health talk, et cetera. So definitely we have state agencies, we have hospitals that coordinate with EPIC, and coalitions. We have a new module out now on domestic violence and children, and the Coalition Against Domestic Violence is partnering with us on that one. Local grants are secured, and also donations from external foundations as well as individuals, philanthropic individuals with common agendas. I just want to switch for a minute. I know yesterday we saw a really cool video. I thought my graphic here of the incomplete bridge was okay, but the video was better, about evidence-based practice dissemination and implementation. So just to highlight what was said yesterday, certainly we have a lot of good research about evidence-based treatment. What happens, though, is there's a gap between transforming that into practice, and that's where Bob has been extremely helpful, Jason Lang, through CHDI's Dissemination and Implementation Support Center. So just an example, training behavioral health practitioners to implement evidence-based treatment. They definitely collaborate with state systems and agencies to translate research and state policies into practice and provide ongoing support to sustain that practice change so it becomes an implemented practice. So one of the areas that has been worked on is trauma-focused cognitive behavioral therapy, and really wonderful. Jason just shared with me outcomes that in the 9 years they've been doing this, over 600 behavioral health clinicians were trained at 35 different agencies. Nearly all the agencies have sustained the practice of trauma-focused CBT for up to 9 years, and over 6,200 children have received this treatment. So through this collaboration of CHDI and other organizations, the training is provided and ongoing monitoring. I just want to mention really quickly, I know Susan McDaniel mentioned yesterday, just switching gears for a moment to training graduate students. So we talked about training the practicing professionals. In terms of training graduate students, the American Psychological Association, one of the divisions there, and the Education Practice Directorate has contributed some funds to developing a course for training graduate students in integrated primary care. So this is psychology graduate students. Really, I hope we talk about doing, and I know Susan's talking about doing collaborative training across disciplines, but we all need to know what our own skills are that we bring to this interdisciplinary table as well. So this is a free course that we are giving to graduate programs, and as we've talked about, at least at our table yesterday, it's difficult for programs to insert a new class and not always do the faculty have the right training. The professors have the right training themselves. So we are giving them a train the trainer. There's notes, there's resources, there's the modules, and we'll be doing a learning collaborative for this also. So graduate programs across the nation can take this, expose their graduate students to this training. It is freely really accessible, and it's flexible, and that's what we were talking about too, that training needs to be flexible so that it can be used as a full semester course if somebody can put that in there. If they can't, it can be used just as a colloquia series. One program in Tennessee is using it as an independent group study. So whatever folks can do to get a new area of curriculum in is helpful. So just in summary, where the rubber meets the road, right? Some of the facilitators for the work that we're talking about here, we need infrastructure. It will be very difficult for everybody just to replicate all these wonderful programs on their own. We need partners with shared agendas, and we need the diverse and blended funding streams. Thank you.